here at the London School, we're running a project called the Vaccine Confidence Project, and we have a global surveillance monitoring information around the world, media, social media, all sorts of information, reports from government, UN, other sources, looking for any what we call signals of public distrust or concerns that come up. We started this project, it was particularly catalyzed by, in 2003, there was a big boycott in northern Nigeria of the polio vaccine. And it took several months before people understood that actually this was more than just a few rumors. 5 states had boycotted the polio vaccine. And it's led to the global spread of polio, and still to this day, almost a decade later, it's still where we have our worst problems. Following that, there was the 2009 H1N1 debacle where the public confidence in vaccines was pretty dismal. And we've had a number of episodes around the world where the public has been questioning and not accepting vaccines. But in the public health community, the main thing that's focused on is adverse events and specific safety concerns. But I'm an anthropologist by training, and I used to head up global communication for immunization at UNICEF. And we started to see an epidemic of outbreaks of public concerns about vaccines. Communities, even governments sometimes questioning, do we need this vaccine or that vaccine? Is that one relevant? Is it safe? Is it really the best choice for our population? We don't like the schedule. And so what the objective of this project is, one, listening, so that when we hear signals of concerns, that we address them early and don't wait until they become a crisis. And the other objective is to create a typology of concerns. What are the concerns? Because they're not just about safety, they're about a number of other things. Some of them are related to beliefs, philosophy, religious. Some of them are distrust about the motives. Is this big business trying to come in with an expensive vaccine? Sometimes it's a schedule. You know, my baby's too young to have these vaccines. There's too many of them. A whole mix of factors. And some of them are straightforward safety concerns. And we monitor it. The objective is early detection of concerns so that the public can get answers to their questions before we have breakdowns in public refusals. Breakdowns in public trust leading to refusals, yes. Well, some of them are prompted by genuine concerns about safety. Every vaccine has a very small risk, like any medicines you take, walking out the door in the morning. Life has its risks, but all of them have a certain amount of risk, and so people want to know. They want to know what is the risk and relative to the benefit. The problem is, because we've been so successful with immunization and people see less of the diseases they're preventing, that there's been a shift to focusing more at the risk of the needle or the reaction than the risk of the disease, because it's different when you see a disease coming around the bend that is either fatal or can make you very sick. Your willingness to take a risk is higher. But when you're not seeing the pressing diseases, it's that. Sometimes it's schedule, sometimes it's motive. There was a lot of concern about the H1N1 vaccine. It exposed to the public health community how little the public really understands about the annual flu vaccine, because some of the anxieties were, this one was made too quickly, this H1N1 vaccine, can we trust it? But actually every year a new flu vaccine is made from a sampling of flu viruses around the world. And it wasn't made really any quicker than the normal annual one. The scale of production was a relatively quick amount of time, but I think that people felt like it was made too quickly. They didn't trust it. They didn't trust the prediction that this was going to be a very bad pandemic. It could have been a very bad pandemic, and had it been a very bad pandemic, I think people would have felt differently. So what are some of the other reasons? As I said, some of them are safety, some of them are motives, some of them are about relevance. Do we really need this? We have a group of pediatricians actually in India who were questioning whether the country needed to introduce the HIB, the Haemophilus influenza B vaccine, when the country wasn't getting enough of the very basic childhood vaccines. So sometimes countries need to make choices. So the distrust and the questioning happens at many levels: parents, community leaders, health professionals, and policymakers. And we're trying to monitor all of it. The implications can be disastrous. They can be little or they can be very big. The biggest concern that we have is that people get distrusting to a point where they refuse a vaccine. And then the biggest concern about that is then it risks having disease outbreaks. And if they're not manageable, we've got a major public health problem. So I would say that's the biggest concern in one vaccine. But what also is a big risk is when people start having distrust about one vaccine or one issue, it leaks into other areas of confidence in the health program, confidence in other vaccines. So it has a reputational risk as well as a specific risk of refusals or disease outbreaks. They happen everywhere around the world, but one of the things that we're looking at, we're monitoring over time, because you can see that sometimes you get a little bit of an emergence of a rumor or questioning. In Congo, it comes for a few days and disappears. We're not so worried about this. In another situation, in northern India, for instance, or Pakistan, we start to get 1, 2, 3, and a persisting rumors spreading, misinformation, leading to people starting to refuse vaccines. Then we get very concerned. We code all of our reports that we get in every day red, yellow, or green. Green means it's just information about a vaccine, new information, but it doesn't have a negative tone to it. Yellow means it's an emerging concern. We need to pay attention to it. Red means we should get on the phone and talk to either the local authority or World Health Organization, because the signal is about a child dying or a perception of a link to a vaccine or a community boycotting a vaccine. We have concerns in the US, in Europe. Europe actually is having quite a few issues with vaccine acceptance, different ones in different countries. And some of them have to do with the history of a previous problem. In the UK, for instance, the MMR anxieties followed the mismanagement of the mad cow bovine encephalopathy. And in France, it was after the tainted HIV blood that then there was a concern about a hepatitis B vaccine. And publics have memories, and they remember all of that. So we're also looking at the contextual factors. What else is going on at the same time? Why would a situation, we can have one rumor in the Congo and the same rumor in India, and in the Congo it doesn't go anywhere, and in another situation the ground is fertile for the spread and the impacts. So our research is trying to understand better what are the factors that make a small rumor into a big impact, because they're every day. There's lots of rumors, misinformation, questions circulating around, and some of them are healthy questioning, and some of them actually can have quite negative impacts. So our work here is to help come up with criteria, a diagnostic tool that can help governments and public health officials see, where should they focus their attention when a concern comes up. Well, A big one is based on the research in the UK that came out in 1998 about MMR vaccine causing bowel disease and autism. That was, it took 10 years for that research to be withdrawn, and there's been multiple reports and studies that have delinked any causal connection, and we still have people who are afraid. Now that actually came from, you know, a sophisticated academic journal, but it happened to have been research that wasn't, the findings were not proven to be true. So the beginnings of that were legitimate. I trust what I read in The Lancet. I trust what I read in other places. But even when other science said that it didn't work, it stayed in the minds of people. And to this day, it's spreading around the world, and I just did an article on the emergence of anti-vaccination groups in South Africa that were quite a bit later, 12 years later, are just starting here because of that rumor. Another one was in India. They were starting to try out the introduction of an HPV vaccine in 2 states to look at different delivery options. And there was a group of women activists and a member of parliament connected with an anti-vaccination group in the US and basically persuaded the government to shut down the project for a number of reasons. They said, why are you pushing an expensive vaccine when we don't even have cervical screening? This must be, you know, big business trying to make money. It's not safe. Don't you know it's not safe? Our friends in the US, our anti-vaccination friends, told us it's not safe. Another issue was the place that they were doing the demonstration with included girls, what they call tribal girls, and girls that they felt were not ethically appropriate to be involving in it. So none of these situations are, the ones that have real impact are usually a mix of factors.